I thought we will talk a little bit about molecular testing in lung cancer, why it's important, how can we incorporate it, and then focus on a few actionable but rare mutations in lung cancer. So without further ado, I'll get started. And with the next 20 to 30 minutes, talk a little bit about the data, and then we'll turn it over to cases. So thank you for submitting them. And I really look forward to discussing them with you. As you all know, 5-year survival for stage 4 lung cancer has tremendously improved. It's gone from less than 5% to greater than 25%, thanks to advances in targeted therapy as well as immunotherapy. This is based upon an improved understanding of the biology of lung cancer. And the question in our clinics is really no longer who should get immunotherapy or who should get targeted therapy, but rather who can avoid chemotherapy. And you can see some of the data here in terms of the incidence, in terms of the mortality in both males on top and females on the bottom. And this is really accelerated based on the understanding of the biology of non-small cell lung cancer. And this is where we are. For at least non-small cell lung cancer, non-squamous histology, we're able to dissect pieces of the pie. We know that there are certain actionable mutations that are listed here. These are the big 7 biomarkers with available targeted agents that are FDA approved in the first-line setting. And you can see that even though lung cancer is very complex, we've made tremendous progress in the delivery of personalized therapy. For example, for EGFR, we have 5 drugs available now, and the same for ALK. And now we have very small subsets of cancer, including NTRK and RET, that have more than 2 or 3 drugs available at any given time. So tremendous progress, and it really behooves us to think about molecular testing and personalized therapy in lung cancer. So not only these targets, but there are other targets that are now actionable. For example, EGFR exon 20, not 1 drug, but 2 drugs are available in the second-line setting. And then KRAS G12C, as many of you are aware, is an immediately actionable target, not in the first-line setting at this point, but definitely second-line setting. And just to give you a flavor of how fast the field is moving and how quickly it's changing, during the pandemic, we've had several approvals. You know, this is a partial listing of approvals, not including drugs for small cell lung cancer and other immunotherapeutics. I've just focused on targeted therapy. And you can see that we've, in a very short period of time, at least had a dozen approvals, including our first approval for targeted therapy in the adjuvant space. So all this time we've been focusing on metastatic disease, but now we have osimertinib available for adjuvant stage 2 to 3 non-small cell lung cancer after receiving chemotherapy. So tremendous progress. So this is how I apply targeted therapy in my practice. This is a typical patient journey at my practice. Patients with a possible diagnosis of stage 4 non-small cell lung cancer are initially either either evaluated by interventional pulmonary or by our interventional radiologists and undergo a bronchoscopy or diagnostic biopsy. And while they're meeting with medical oncology and undergoing disease evaluation in terms of PET and MRI, we usually recommend that they get PD-L1 and next generation gene sequencing on the tissue. And next generation gene sequencing should at least include the available and actionable biomarkers that I'll go through in a moment. But why is this important? I think firstly, we know that for both our non-squamous and squamous histology, we need to know what the PD-L1 level is so that we can recommend either monotherapy or chemoimmunotherapy. But especially for the non-squamous patients on the left, there's a big bifurcation where patients with actionable mutations can actually skip all those steps and go straight to targeted therapy. With the availability of molecular data, not only can we personalize medicine, but we can improve outcomes, as demonstrated by improved overall survival in patients with EGFR mutant lung cancer, for example. But we can also lower toxicity. We can lower the impact that cancer has on patients' lives by removing the IV option. Comprehensive molecular testing in non-small cell lung cancer is now included in national guidelines, and it is defined as complete EGFR are ALK, BRAF, ROT, RET, and NTRK 1, 2, and 3 testing. And I just want to make sure that we all are on the same page, that their institution, for example, has a DNA-based reflex panel that covers 156 genes that will cover all of these. But we also run a simultaneous RNA fusion panel because there is data that some of the fusions, as well as some of the MET exon 14 mutations and NTRK fusions, may be missed on DNA testing alone. So we usually recommend both DNA and RNA fusion panels when being conducted on solid tumor. The other thing I will mention is that we'll talk a little bit about liquid biopsy up ahead in the talk. The Guardant 360 panel. So Guardant has 2 liquid biopsy assays. One is a shorter panel with a much quicker turnaround that they call the Guardant 360 CDX. And that does not cover all 3 of the NTRK genes. It covers NTRK 1 and 3, doesn't cover 2. The longer panel, or the larger panel, which is the 500 gene panel, does cover all of the genes. However, it does take a little bit longer time. The Foundation 1 liquid panel does cover all of them. So it's just a matter of being aware that, NTRK 2 is very rare, but currently comprehensive testing is defined by all of these being tested. So how do we go about testing for these, and how do we apply this in our practice is the question. And traditionally, our way of doing this has been by using tissue that's obtained at the time of diagnostic biopsy, which is then assessed for adequacy, and then tumor tissue is submitted for DNA assessment. However, we now have the ability to minimally invasively assess the blood samples, use the circulating tumor DNA, send it for plasma ctDNA analysis. How do I apply this in clinic? And I want to leave you with a very simple algorithm that has now actually made its way into national guidelines. So when a patient with newly diagnosed lung cancer presents to me in clinic, one of the first things that I ask is tissue available? More so for my non-squamous, non-small cell lung cancer patients. And this is an important question for me because I often see a lot of second opinions, and the tissue may have been sent by an outside physician to another lab, or sometimes it may be exhausted. And if it is exhausted, and let's say we are thinking that tissue is not available, or at least it's not at Penn, my next step is I will proceed with plasma ctDNA, NGS, or genotyping. If I find a mutation, I usually act upon it and deliver therapy. If no mutation is found, then really the question is, what am I missing? Even if it's a patient with a smoking history, I do go in and I repeat the tissue biopsy because, as you know, BRAF mutations, MET exon 14 skipping mutations, and others can also occur in patients with a history of smoking. So I think we should not limit our testing to a particular phenotype and make every effort possible, especially in cases when ctDNA is negative. If tissue is available, I think we have many more approaches. For example, one of the approaches may be to go ahead with concurrent testing, and that's usually in patients where tissue is adequate, meaning that if tissue is enough for analysis, and our pathologists at our center actually give us an indication right on the path report that yes, there is enough DNA for analysis. So in those situations, you can still go ahead with concurrent testing, ordering both tissue and plasma, because there is a lot of data to say that even if you order tissue testing, you can detect many more mutations with plasma if in case your tissue fails. The other option would be to proceed with tissue testing first, recognizing that it may take a long time, right? Tissue testing does take a longer time. The turnaround time is usually 2 to 3 weeks. So if we wait for tissue testing, and then if it comes back negative, then we're adding more time at the back end to then get plasma. So it may be a time issue. And then the third option is also to do plasma ctDNA first and then implement tissue testing right after that, again, recognizing that if plasma ctDNA is negative, we're again adding time. If tissue is available, but my pathologist tells me it's actually inadequate for testing, I usually follow the approach that I use if tissue were unavailable. So I always start with plasma first in those situations. This has made its way into national guidelines as well as some papers recommending strategies for testing. With that, I'd like to turn over to a few new approvals as well as treatment of patients with, less frequent actionable alterations. So the first one we'll talk about is ALK TKIs. So, this is obviously a very important subset. It's a small subset. It accounts for about 2 to 4% of all non-small cell lung cancer patients, often seen in never smokers. And we now have 5 drugs, 2 of which have been around, I should say alectinib really became the standard drug because it was the first drug to be compared to crizotinib in the first line setting in a trial called the Global ALK trial. That's depicted on the left, where we saw data with a median progression-free survival not reached with alectinib compared to 11.1 months with crizotinib at the time that it was reported, with a really significant hazard ratio of 0.47. You can see that it was updated in 2018, and at that time we saw a progression-free survival of 34.8 months. I mean, that's close to 3 years, and that's progression-free survival, just remarkable data. And given this data, it quickly became adopted as the first-line setting. And most recently, we saw data on brigatinib, which also compared its use to crizotinib in the frontline setting. And you can see, again, very impressive hazard ratios of 0.49. Again, both of these are PFS data looking very impressive. Very recently, lorlatinib has been approved. It's a 3rd generation ALK TKI that's been approved in the frontline setting. Now, this trial also compared, this is called the CROWN trial, also compared it to crizotinib in the frontline setting. Hazard ratio is actually very impressive for progression-free survival. You can see it's 0.28. PFS median not reached, and you can see, the 50% mark is not even reached. I mean, we can't even say that this is going to be 36 months. It's probably going to be longer. However, skeptics or critiques of this trial include that lorlatinib has been compared to now not a current standard. It should have been either compared to alectinib or it should have been compared to brigatinib, because that's what really we've been using in the frontline setting. But regardless, having said that, really impressive data here. If we move on, this is a quick summary far left. Then we had ceritinib, which had a significant side effect profile, including Lft abnormalities. And then we have ALK with alectinib, brigatinib, and then lorlatinib. And I would like you to pay some attention to the median PFSs here in the second to last row, 34.8 months reported with alectinib, and then really not reached with brigatinib and lorlatinib, much higher than what we expect with crizotinib on the left and ceritinib in the column next to it. And then overall response rates, you can see that, very impressive overall. This is probably one of the TKIs that gives us such brisk, robust response rates. Even with EGFR TKIs, we see response rates in the 70 to 80% or 60 to 80% range, but this is much higher and just very impressive data. ALK is atypical compared to the other, let's say, EGFR or BRAF or MET, that there seem to be, with the fusions that we'll talk about, there seem to be significant cumulative incidence of CNS Mets. And these tend to be highest in patients with ALK compared with other receptor tyrosine kinases. So it's important to have data and activity with other agents and CNS activity with agents. So on the global ALK study on the left, you'll see that the incidence of CNS progression was much lower with alectinib. And on the Alta-1 study, you'll see that survival without intracranial disease progression was much better with brigatinib as compared to crizotinib. So these drugs have very high intracranial penetration. And the same on the Crown study with lorlatinib, that intracranial time to progression by best intracranial response. It's just spectacular. I mean, very few patients here, but you can see hazard ratio is 0.07. I mean, lorlatinib is extremely effective in the CNS. So this is just summary of the trials, but I added a row on intracranial activity, and you can see 81% intracranial activity with alectinib, 82% with lorlatinib, and many of these patients can actually avoid stereotactic radiation, especially if they present with asymptomatic brain mets and small disease, can certainly begin with the first-line TKI. Some side effect profile differences. All three drugs are approved in the first-line setting. So we have alectinib, which usually is associated with anemia and Lft abnormalities. There may be some peripheral edema. It's important to remember that brigatinib is associated with early pulmonary toxicity. So there's actually a dose recommendation that you start with 90 a day for a week, and then you increase it to 180. And then lorlatinib finally has a very curious side effect profile also, where you can have lipid abnormalities, including hypercholesterolemia and hypertriglyceridemia. You can also have cognitive impairment. Patients often feel like they are fuzzy on details, or they have ADHD where they can't remember what they were going to do, and then they tend to forget things. It doesn't really get worse over time, but it's something that patients just learn to live with. But it's important to remember that this can be limiting for some patients in practice. And then a couple of slides about what to do in the later line setting. Before lorlatinib became approved in the frontline setting, it was our drug of choice in the second line setting, because it's a very active third generation ALK TKI. Its activity has been shown in phase 1 experience across multiple cohorts, including those that received more than one ALK TKI. You can see impressive waterfall plot with lorlatinib. And it does have CNS responses, even in patients that have more than 2 TKIs before. So on the left, you'll see overall response rate of 38.7% in these patients with an intracranial overall response rate of 53%. So how do we sequence ALK therapies? And this is what how I tend to think about ALK. Pre-2017 or pre-alectinib, first generation TKI was king, and we used to use crizotinib and then use alectinib, suritinib, or brigatinib upon progression. However, in the post 2017 era, we now have 4 ALK TKIs that are available for the frontline setting. Nobody uses crizotinib in the first line setting anymore, but definitely can use either alectinib, brigatinib, or lorlatinib. We have to just decide what's best for our patient given the side effect profile. And then you could use, depending on what agent has been used, can come in with lorlatinib in the second line setting, or could also come in with chemotherapy. There's a lot of data to support continuing a TKI. I won't say a lot of data. There's data to support continuing a TKI with chemotherapy, and absolutely no real data to guide use of immunotherapy in this setting. Moving on, a quick few slides about ROS1. ROS1 testing is currently recommended for all patients with non-squamous histology. There are different ways to test for ROS, so I thought I'll spend just a couple of minutes here. You can use a FISH break-apart probe, but it can underdetect some different variants called the FIG ROS1 variant. IHC for ROS1 is actually not recommended. So IHC for ALK can be used, and it's actually okay to use that even to prescribe therapy, but IHC for ROS1 is actually very hit or miss, and follow-up confirmation is necessary, associated with a lot of false positives actually. NGS assays can be used, but as I said, some NGS assays may miss fusions. So if an NGS assay is being used, both DNA and RNA sequencing should be used. And then targeted PCR is an option. However, targeted PCR basically looks for one particular kind of fusion and may miss novel partners of ROS1. Here is a summary of all the data and trials for ROS1. I would like you to remember two things. Crizotinib is still a very relevant drug for this fusion. You can see response rates of the 72% range. And entrectinib is the new player on the block with a response rate of 77%. You can see duration of response very similar for both crizotinib and entrectinib. Entrectinib does have a different side effect profile where it does cause edema. And crizotinib is associated with peripheral edema, but also with this characteristic vision abnormality where patients may have floaters. In the later line setting, once patients have progressed on crizotinib, obviously chemotherapy is a reasonable approach, but there's emerging data that a drug called repotrectinib may actually be helpful in patients in ROS1 altered non-small cell lung cancer in the resistant setting, when especially they have this mutation in ROS1 called the G2032R mutation. This drug seems to be very active, and as you can see, the waterfall plot, many responses seen with this drug compared to very few with lorlatinib. So I think it may be worth sequencing these patients upon progression after crizotinib or even entrectinib. So in summary, second and third generation ALK TKIs are the current standard of care for first-line management of ALK rearranged non-small cell lung cancer. Now we have three drugs, alectinib, brigatinib, and lorlatinib. And then ROS1 is a rare subgroup. Crizotinib and entrectinib both have activity, and variable activity has been demonstrated in the resistant setting. So that's sort of our summary for ALK and ROS, but we'll go on to talk a little bit about RET alterations in non-small cell lung cancer. And, RET is a very interesting fusion protein, as well as a RET mutation, because it's been implicated in many different cancers. And I would say that this discovery of RET dates back to 1985, when they were first described in lymphoma. And fast forward, we now have approval for two drugs in both non-small cell lung cancer as well as in thyroid cancer. Hundreds of patients enrolled on trials across the world, significant activity noted. Again, a word on how to detect this. You can use IHC, FISH, but RNA-based assays seem to be the best. This is a picture of a RET fusion using the FISH break-apart probe assay. So Celpercatinib is the first drug we'll talk about. It's LOXO292, very potent selective RET inhibitor. It's not a dirty kinase inhibitor. It doesn't have a lot of activity across different kinomes. It's a very specific inhibitor, and was evaluated in this clinical trial called Libretto, that looked at 700 patients across various lines of treatment for both fusion positive metastatic lung cancer or thyroid cancer. And we looked at both treatment naive as well as pre-treated patients with overall outcomes of response rate and duration of response. And you can see that efficacy of Celpercatinib was amazing. I mean, this waterfall plot has basically all of the patients except 3 on the right side of the waterfall plot. Out of these 105 patients, you can see overall response rate about 68% and CNS activity of about 91%, including activity in patients who had chemotherapy or an ICI or multikinase inhibitor. You can see amongst treatment naive patients, response rate is 85%. And then you can see some of the side effect profile, overall well-tolerated drug, but I want to focus on a couple of grade 3 events. Hypertension, this is a VEGF inhibitor, hypertension is expected. And then we can also see Lft abnormalities, as you can see here, 7% and 6%. Overall, still, well-tolerated drug. And I certainly have patients on this where I have started with the usual dose, and sometimes I've required a dose reduction. We can certainly talk about it during the cases. And then quickly a word on Celpercatinib, which is the other agent that has also been studied in a very similar setting in a trial called the ARROW trial. Again, you'll see significant activity. Just a word on the response rates come in at the very similar sort of 58% and 60% in prior platinum exposure. This drug does have once a day dosing, and it's 400 milligrams as compared to Celpercatinib, which is twice a day. And then here again, we see side effect profile, grade 3 or above hypertension and neutropenia are the top 2 treatment-related side effects, which are grade 3 or higher. These drugs are very active in the CNS. These are examples of patients that had brain mets at presentation and within 2 months had responses on these drugs without need for SRS or intracranial or radiation therapy. Lastly, we will turn our attention to cases.
Yes, hi. Thank you again for, I guess, the lecture and for inviting me to present. So this is a patient that I initially took from a colleague that was treating her, Asian, 56, no prior history of smoking. She was uninsured at the beginning. She presented with worsening shortness of breath, hemoptysis, and intentional weight loss. Went to the county hospital ER. She was scanned and it showed a right upper lobe mass. She had low hemoglobin, so she was admitted for transfusion and workup, so pulmonary, and eventually was diagnosed with a post-obstructive pneumonia, mediastinal lymphadenopathy, and then liver and adrenal glands. So through the bronchoscopy, they managed to get a tissue biopsy, and that came as moderately differentiated adenocarcinoma. TTF1 positive was consistent with lung primary. Her initial staging scan after discharge showed negative MRI of the head. But again, the patient was uninsured, and due to this, we managed to get foundation testing for NGS, pretty much at a reduced cost, and showed ALK fusion rearrangement. But due to lack of funding, she was not really started on alectinib. She only had the choice of crizotinib, which was available to start immediately. So she started on that first line at 400 twice a day. She did have some lower extremity edema, mild nausea, some diarrhea, and lymphopenia. Eventually, due to worsening performance status, her dose had to be reduced to 200 twice a day. But then she managed to stay on treatment for a total of 14 months until early this year, when she now presents with some blurry vision and headaches and right upper extremity weakness. So now a brain MRI shows 2 new lesions in the brain, one of which measures up to 4 centimeters with some associated edema and no other evidence of metastasis in the rest of the body. So the neurosurgery service was consulted. They came and discussed with the patient. Due to the highly symptomatic brain lesion, they decided to go ahead and resect the biggest one, which confirmed recurrent adenocarcinoma. The repeat NGS again showed ALK fusion rearrangement. And then the patient received the gamma knife to the second lesion and then was switched to alectinib that was now guaranteed due to change in insurance. She did develop some transaminitis on treatment and some mild hyperbilirubinemia. There was no obstruction in the ultrasound. I was concerned that maybe I was missing a potential liver metastasis, but it was likely just toxicity from the treatment. And I just also reduced her treatment to 450 twice a day, and she appears to be tolerating it decently well.
That's great. I've seen hyperbilirubinemia and grade 2 to 3 Lft abnormalities very frequently with alectinib, and they do seem to respond to dose reduction. I
have a question, Dr. Agarwal. So I was just thinking, in solid tumors which are not curable, we try to use all the available drugs in a sequential fashion in order to improve the overall disease-free and overall survival. So I was kind of curious to know what's your opinion. Is it not more rational to use the first generation, then whatever mileage you can get, then go on to the second generation, then ultimately the third generation lorlatinib? So what's the data regarding the the progression-free survivals of each step of treatment, as opposed to like post 2017 options, which includes you go straight to the second or third generation, then after you fail that, you go on to the chemotherapy option? Just
yeah, I think that's an excellent question. I think ALK is a very unique subset in terms of CNS progression seems to be the biggest thing. And we find that a first generation ALK TKI such as crizotinib really does not have much in the way of intracranial penetration at all. Even if it controls the disease, it only controls the disease for 11, 12 months. When we are seeing a tripling of progression-free survival with a PFS of about 37 months or 34 and a half months with alectinib, along with significant CNS benefit, I think it just behooves us to say we should come in with the best treatment and not try and sequentially use treatments to add up the math, just because best in this setting is not only PFS advantage, but it's also CNS penetration. It's also better tolerability and better activity against emergent mutations compared to crizotinib. So, you know, I think now the question is more of, do you use lorlatinib first or do you use alectinib first? Because lorlatinib can give you first, you know, it's a third generation TKI. And, you know, do you save that for the second line setting after they progress, which I certainly do in my setting, just because I find that alectinib or brigatinib, they have such good toxicity profile. Why shouldn't I come in with that first, get that 34, 36 months first? And then if I need, then I can add on the lorlatinib. So I do think that what you're saying is very reasonable in terms of adding the math, but I just can't justify using crizotinib given the poor performance against the three other drugs now.